All right, so good evening once again. And first of all, I would like to thank the chairperson and all the panelists of this session, and also to the All India Ophthalmic Society for giving us a chance to speak upon this. Now, what I'm going to basically talk about is cataract with macular problems. Is my pre-op protocol correct? And now, basically what I will be talking about is something which has already been dwelt in detail by the earlier speakers. Dr. Rajan Narayanan just right now mentioned that we have to look at the patient as a whole. We tend to sometimes forget or differentiate ourselves into either we are cataract surgeons or retina specialists or oculoplasty or whatever. What we tend to often forget is that we start as ophthalmologists. That means we are supposed to take care of the entire eye, not just focus on the logistics of cornea or cataract or retina in person. So whenever you see a patient, there are a few things about what is your pre-op protocol. Now look at the systemic parameters of the patient. Is the patient an uncontrolled diabetic or not? What's happening to the systemic conditions of the body? When you are evaluating a cataract, obviously it makes sense to look at the zonular status of the lens, because if there is a zonular weakness, you are probably having a risk of the lens getting dislocated. There will be refractory surprises if we don't look at these points or factors, if we don't keep them in mind while we are evaluating your patients. And therefore, like any other evaluation for any pathology, not only in eye but any part of the body, take a meticulous history. Correlate vision, look at the retina. One of our earlier speakers, Dr. Vaidya, just said it makes sense to correlate the vision and see if the lack or the discrepancy in vision can be accounted by the cataract. If that is the case, it's good enough. But if you have got a cataract which is not commensurate with the amount of vision loss, it makes sense for even otherwise to keep in mind that there may be something else which you are dealing with. And therefore comes the part, what we are supposed to do for every patient, a comprehensive, complete ophthalmic evaluation, which includes best corrected visual acuity, a meticulous slit lamp evaluation, look at RAPD. If there is any neovascularization of iris or angles, obviously it makes sense to look at that. IOP, fundus examination. In cases apart from our clinical skills, sometimes we may need to resort to using ancillary investigations like an angiogram, OCT, or in cases where you can't visualize the retina because of the fact that you've got a very thick, dense cataract, a B scan if needed in those cases. So we have already had some talks in this session which have dealt about macular edema, epiretinal membranes, possibly vitreomacular traction is something which we will deal with in diabetes. These are points which you need to keep in mind, and therefore let me show you some cases where the patient was initially referred apart from cataract, and when we saw the patient, we saw this was a patient who had a macular hole. Now because of the fact that there is a macular hole, obviously if you go ahead and only do a cataract surgery, sometimes you may end up with a suboptimal visual outcome. So these are points which you need to keep in mind apart from this. Another patient who was referred to the retina services with a cataract, but apart from the cataract, when you do a retinal evaluation, you see these pigmentary changes and a vitreomacular adhesion. This was a patient who, apart from having diabetes and hypertension, also had parafoveal telangiectasias. So you may see retinal pathologies which may probably compromise on vision. Another case which shows how important it is to do a complete evaluation. So this was a patient referred to the clinic with a vision of 20/40. But when you look at the retina, what you see is a sub-ILM hemorrhage and a white-centered hemorrhage. This was a 41-year-old male patient referred to the retina clinic. And when we did an OCT, we found this sub-ILM hemorrhage, and there was a single white-centered hemorrhage. When we investigate the patient systemically, what we found was blast cells and myeloblasts. This was a patient of a known case of CML, which we were able to pick up because of the fact that we went ahead and investigated what a single white-centered hemorrhage. So this basically highlights how important a good complete evaluation is as part of our clinical evaluation. Apart from that, what you also need to keep in mind are any inflammatory pathology. So this was a patient with cataract, but with multiple diffuse fine stellate KPs, no CME, no synechiae. This is a case of Fuchs uveitis. So again, these are cases whom you need to counsel for the fact that you may still have some vitreous opacities in the eye. You may have a risk of IOP elevation before you go ahead and do a cataract surgery also in these cases. So when you see multiple fine diffuse KPs in a patient who predominantly might have a posterior subcapsular cataract, no CME or other obvious signs of inflammation, Fuchs may also be one of your differentials. Apart from that, look for any sequelae of any post or old uveitis. So in cases where there is a uveitis, you may need to ensure that the eye is quiescent for at least 2 to 3 months before you go ahead with a cataract surgery. So these are some of the points. I know this may sound repetitive, but these are actually supposed to be a part of a complete evaluation for any of our patients, not just for cataract. One more patient, now this opacity which you are seeing, this is basically because of the dense posterior polar cataract which the patient has. And this patient also has these pigmentary changes in the eye and a lesion over in the superior temporal quadrant. This patient was actually referred to us thinking it's a uveitic pathology, but what you also need to look at is look at the other eye. The other eye had a pachychoroid. So that was a patient with a scar subsequent to PCV and peripheral subretinal heme. So it makes sense to look at both eyes of the patient do a complete meticulous ophthalmic evaluation, and that should be a part of your pre-op protocol. So take a history, correlate vision, and a complete ophthalmic evaluation, and that should complete your pre-op evaluation for all patients. Thank you.
Thanks, MUDIT. Thank